On the count of 3, live video is starting. Welcome, everyone. In the spirit of truth and reconciliation, Doula Canada acknowledges that we are gathered today on the customary and traditional lands of the enduring presence of all First Nations, Indigenous, Métis, and Inuit peoples. Doula Canada's work primarily takes place on Turtle Island, which has been a site of human activity for over 15,000 years and is the unceded territory of Indigenous peoples. Please take a few moments to find out more about the traditional territories, languages, and treaties of where you are located. You can do this at native-land.ca. As we learn together, we ask that you reflect on the ongoing role that colonialism plays in pregnancy, birth, and parenting in your own relationship to this work. We pay respect to Indigenous birth workers, both past and present, including any of those who may be here with us today. Hi, everyone. My name is Zakira, and I am EDI co-lead at Doula Canada. And we're here for season 2, episode 2 of Just Birth, our monthly roundtable series on equity and social justice in perinatal and reproductive care. In today's discussion, we are talking about fertility hunger games. So as we know, there's a significant element of chance involved in what is involved for different people in starting their family. And that game of chance can be influenced by many factors that are outside of a person's control, including systemic forms of injustice. So we're here tonight with 3 guests to talk about what that looks in terms of fertility care access and how birth workers in the fertility space can support clients who are navigating this journey and where they are impacted by systemic injustice and marginalization. Excuse me, we have joining us this evening, this afternoon. I usually do this at 7 p.m. It's the afternoon here in Toronto, where I'm located. We have with us Zakira Saleh, who is a certified fertility doula. Her passion for fertility stems from both personal as well as professional experience. She has worked with an OBGYN for almost 10 years and went through fertility treatments to conceive her son. She has also experienced recurrent pregnancy losses, which allows her to understand the pain that comes with a miscarriage. And she's currently working at the Womb Wellness Center in Ontario as a fertility doula. We also have with us Jessica Palmquist. She is the instructor and program coordinator of our Fertility Support program. And Jessica is passionate about supporting individuals and families through life's many journeys as they navigate through calm and stormy seas, so to speak, in terms of this fertility journey. Jessica helps her clients transition through the new chapters of their life with as much grace and ease as possible, while letting them know that they are never alone. Okay, and we also have with us another alumni of the fertility program, Laine, Halpern, Zisman. Laine is a postdoctoral research fellow at the University of Victoria's School of Public Health and Social Policy. Her research and teaching focus on queer performance and 2S LGBTQ+ health equity. In addition to her scholarly work, Laine is a queer family building doula with Birthmark and facilitates Seed and Sprouts monthly family building support group for 2S LGBTQ+ families. Welcome, everyone. Thank you so much for being here. So we've heard in your intros a little bit about the work that you each do in the fertility space. So we know from statistics that 1 in 6 people who are trying to conceive will be impacted by infertility. So that means struggling for over a year to conceive, using conventional methods. And when people are struggling to conceive, can you walk us a little bit through what their options look like? How would it come to somebody's attention that they need some interventions in this regard? And what are their options look like?
You can go first. So usually they're trying to conceive and it's been 12 months. The first thing that they would do is they would reach out to their doctor to try to get a referral to a fertility clinic. And then I think what happens is like the doctor would first ask them, how long have you been trying? The doctor can do a panel of blood work, get like the initial ultrasound, things done to see if there's any reason why they're not able to conceive and it's been taking a long time. Also like determining on how they're determining their fertile window. So like, are they even timing it the right way? So right now, because I think the fertility doulas are so new, that's a new thing that people are reaching out more to doulas, because instead of just guessing, they're going through a doula so that they can determine when actually they are ovulating. And that way it's not like a guessing game.
I can jump in. Yeah, maybe just to add to that a little bit. I think so in my work, I'm often working with folks who don't have all the things you need to make a baby readily available. So we know we need 3 things to make a baby. We need viable eggs, viable sperm, and a uterus to grow it in, right? Like, so if we don't have one of those 3 things, we can't make a baby. So we might not have those things readily available because we might not have a parent or a donor to provide those or a surrogate to provide those things, or we might not have those things readily available because for some reason it's not working in our own bodies. So regardless, we need to figure out what's going on and how we're going to get those 3 things together. So I think that happens through conversation. It happens through like figuring out your own cycle. It happens through perhaps like looking for a donor if you don't have those things available. And then it happens through a few different decisions that I think, as Zakira was saying, happen now a lot more with doulas maybe than they used to before. So decisions like, am I going to figure this out at home, or am I going to go to a clinic? And if I'm going to go to a clinic, how do I decide what clinic to go to? And that's a really big question. And also the question of like, what is my ideal first method to try as my next step?
And I will further add on to that. So for individuals that maybe are 35 years or older, they don't need to wait the typical 12 months. That maybe it'll be 6 months that they'll be trying, typically with cycle charting and timed intercourse. And without success, after 6 months, we recommend that they seek support. For individuals who do not have a family doctor, which is very common in Canada, they should seek support through maybe a walk-in clinic or a sexual health center to discuss, what they're going through, to see if they could get a requisition for a doctor or to get on a wait list with a fertility clinic. It sometimes takes time to get in with some specialists in Canada, whether it be a urologist or a gynecologist, and sometimes clinics, depending on what city. So we always advise, get on that wait list as soon as possible, even if you're not necessarily ready within the next couple months to get in. It's best to just be on that list and ready and waiting for that appointment to come up. And then if you need to, accessing those walk-in clinics, those sexual health clinics, to get the access that you need, and really advocating for the support you need in terms of growing your family.
Okay, thank you, everybody, sort of for that walk through from your different perspectives in the settings where you work. I feel like there's already a lot to unpack because you've touched on age being a factor in terms of when it's time to seek medical care. You've touched on whether or not you have the 3 ingredients that Laine talked about readily available, or if you don't really have those 3 things to start your journey with, just sort of trying at home with things like timed intercourse and those kinds of options. What are some of the factors that you've seen from there? So we've talked a bit about age, sexual orientation. What impact is all of this going to have on the likelihood of your fertility journey ending with a baby? Anyone can start.
I'll jump in and start that conversation. So a couple things are access. So individuals need access to either clinics, doctors, support systems in the medical field. They also need funds. So if they're unable to grow their family in the traditional ways at home, as Elaine talked about with those 3 parts, at home, on your own, then you need funds, because a lot of these tests and a lot of these ways of growing your family are not, unfortunately, free or funded by the government. Some provinces, not all, provide some grants where you can get some coverage. It does not cover the total cost. So that's something that families do need to be aware of, is that, sometimes it means that there's a money investment towards that. There's a time investment too. So families need the time to be able to take time off work, to go to appointments during the day, to be able to go through treatment, to get testing done, to be on wait lists. And so sometimes they're not able to necessarily access the support they need when they want it. It means just waiting for that system and that appointment to come up. And those are 3 major factors to consider when growing your family.
I can jump in. Yeah, I agree. That's great.
Mhm.
And it got me thinking about so many things. And one of the things that I'm thinking about just in our conversation so far is why people might hold off on getting on that wait list, right? So yes, things like funding, definitely. Every province is so different in terms of the coverage they provide. And that's coverage not just for things like IVF, but also for things like IUIs and testing. But I think that one of the big things that stop us even from making that initial consultation, that initial phone call, is stigma. There's so much stigma around infertility. There's so much fear around what you're going to find out. And I think that could make people wait a lot longer or feel like the space isn't for them. I know we'll talk about this later, but I think that fertility clinics and doctors' offices, all healthcare is not equitable at all. And I think there is really valid fear for not contacting medical professionals. So I just want to name that as a reason, that as a barrier for access. The stigma around oh, something's wrong with me, I think can really stop us from reaching out. But I also want to offer maybe a few things that can respond to those stigmas and fears. So, and barriers. So things like communities, like finding a community online or in person where people have gone through similar things and asking them questions, I think is huge, because it can make you feel seen, validate your experiences, and give you good insights into next steps. Obviously support resources like a doula, but also in terms of barriers for finances, looking in, if you have any private insurance from work, looking into that, because that can cover medical fees, even if it doesn't cover IVF, could cover medication. So those are just a few things that are thinking about access that can help us maybe overcome some of that fear. And yeah, I think also just keeping in mind one more thing, that sometimes we think about fertility treatment, our brain goes big really quickly and we're like, I'm going to have to do IVF. But sometimes if you are a person with a uterus and eggs, maybe you're just not ovulating and you just need oral medication, right? Maybe you're just doing things at the wrong time. It could be a much simpler fix than you're making it in your head. So I think just removing the fear and taking that first step for a consultation can actually help a lot in creating a plan.
Okay, thank you so much. There's already so many strands that I want to pick out from that, but I want to hear, Zakira, from you first on this aspect of this session.
Okay, so Jessica and Laine covered the main things, but I just wanted to also add to Laine's where the fear. I've heard it so many times, just when I was working, when the OB would say okay, maybe it's time now, you need to be referred to a fertility clinic. And the first thing they would come out and say to me is, I'm so scared of needles. And immediately that's their first thought is that, they're going to have to do IVF. So it's there's so many other options before.
Okay. So I'm hearing multiple threads there. So I'm hearing that obviously money is a big factor. That it sounds like if you have deeper pockets, your likelihood of kind of coming out of this with the outcome of a baby is going to be higher than if you have more shallow pockets. I am hearing that access to primary care is a factor here because this is a specialist level of care. So if you don't have a family physician, you have to access these other kinds of resources, walk-in services. We know that in general, that's not as effective as a way to get primary care than having your own physician who gives you sort of continuity with that access. And it sounds like also at the same time, there's some waiting involved to get rostered with these clinics. And it sounds like the education piece is not something that people have equal access to, just in terms of knowing about the options. I know that, like, obviously the sex ed that I got as a teenager in the 90s was geared towards teenagers. It was mostly focused on what to do to not get pregnant. What to do to get pregnant is not something that I ever got any formal teaching on. We were kind of like at the age where this became relevant. It's a little bit like you have to work backwards from like everything you were taught about, like what not to do as a teenager to figure out what to do. So tell me a little bit more about this intersection of factors of like, it seems like you have to be a fairly privileged person in a lot of ways to get this access. You've got to have the money, the access to healthcare, the access to education. What does this look like? I know, Laine, you mentioned you work at Birthmark, which is a nonprofit. I imagine that some of your clients there don't really have very deep pockets. And perhaps don't necessarily have equal access to education and some of these other resources. I'd be interested in hearing from all of you on how this plays out for your different clients and how this kind of works out for them.
I can start. I think so. I think it's very province specific. So finding out, like doing a Google search and finding out what kind of resources are available to you in your province, I think is a first step. But I think recognizing that, yes, there's huge barriers to all healthcare for people of the global majority, for Indigenous folk, for queer and trans folk, that is a reality of living in a settler colonial nation. There are free resources available and there are culturally specific community resources available. And I think finding those can help us to figure out the first steps. So I think one of the things is to recognize that like you are not alone. Other people have done this before and you don't need to recreate the wheel. So figuring out where you can get information is massive. In terms of Ontario, which is where I am, not all fertility clinics require a referral. So that's just a note. So you don't necessarily need to go to a family doctor in order to get a referral to a fertility clinic. If you are doing IVF, the medications are quite expensive, but the first round, you go on a waiting list and you can get the first round covered. And IUIs are actually covered by our provincial healthcare. So there are options available. And if you have private insurance, that can cover some of the medications. So there are some options available if you don't have a lot of funds. There's also some organizations that do have funds available. And those, again, some of them are culturally specific or community specific. So reaching out to communities, reaching out to organizations that can help you find answers, I think is a really good first step, so that you're not just like sitting at home feeling like you're not going to be able to grow your family. Like I really believe like we can find a way to grow families, and for everyone that's going to be different. And I think also just acknowledging the barriers that exist allows us to start to address them.
Okay. I mean, I imagine this is some of where a fertility doula would come in terms of helping you figure out where those resources are in your community that you can tap into, right? Zakira and Jessica, do you have any thoughts on sort of?
Yeah, I actually did notice that a lot of insurance companies now are adding fertility medications into their plans. So I think that's a really big first step, going forward.
Okay, great.
Yeah, I'll add on to that. For individuals in Ontario who identify as BIPOC, then maybe working with a company called Mummy Monitor might help, where you can get access to free doula support. Maybe fertility doula support would be under that category as well. For individuals in small communities, travel might need to be something you'll have to consider, like going outside of your community to get that support that you need. And often you can get those appointments virtually. So I know I had clients in Nova Scotia that were meeting and getting appointments much sooner with clinics in Toronto rather than waiting for clinics in Nova Scotia. And they were getting the consults virtually. They were able to get the requisitions sent to their home city pharmacy and getting the support they need. And like you said, it doesn't mean IVF. Maybe it means oral medications. You can get that prescription quickly, get it sent to your home pharmacy and move forward. So there are things that we can do. And then I even know of clients who did self-funding. So they did GoFundMe accounts, they created an Instagram account to share their journey, ask their friends and family members to donate, ask strangers to donate. I know of individuals who created online stores where they would make fertility related apparel, and they would sell that to raise money to pay for their fertility treatments. So many different creative ways. And then the other option is to get a different job. So for some people, they get a part-time job at Starbucks or Walmart because they actually have exceptional fertility care. And so be a barista part-time to get that IVF coverage within the 3 to 6 months that you're required to work there. I know that Starbucks has excellent IVF coverage. So if anyone's looking for support, I've heard Walmart and others. So maybe looking for a new part-time job if this is important to you, take the steps to do it right away and don't wait.
Thank you. That's so interesting about the different ways that people find to get access when it's not necessarily made obvious what the options would be to navigate. And I think you've already shared some really great practical tips for our listeners. I want to pick up on a couple of other things that you've all said. So when people think about interventions for fertility, you're right. I think there's this tendency to go to the most invasive medicalized options possible, IVF, tons of needles, all of that. So full disclosure, I am a queer person myself. I have one child where we did not use clinical interventions to conceive our child. We did kind of DIY at home options. And I know that there can be some real attitudinal challenges for people, even within queer spaces. Going the route of using medicalized services can be really seen as the right way to start your family. And I'm seeing some attitudinal stories emerge, I think, Laine, from what you said about stigma, and also just all of the variation, and some companies being really receptive to having some insurance policies being really supportive, some provinces being supportive, and others not. Where do you feel like all of these attitudinal pieces fit in for the clients that you work with? I know that when the funding that was made available in Ontario was first implemented, some of the discussions that I remember online at the time were, well, if you can't afford this care, how would you afford raising your family, right? To me, I think it's an absurd question to ask because, hi, it's really expensive. Like most of us can't afford our own medical care. And that's one of the principles on which social services in Canada are based. But this seems to be an aspect where it's seen as outside of basic healthcare that we're all entitled to. What are your thoughts on all of that and the attitudinal dimension of this aspect of care? I know I talked a lot. If you need me to restate the question, I'm happy to. I'm just sort of wondering how you feel the role of stigma, and particularly class-based stigma, I guess is what I'm getting at, around who should parent and whether or not access to this care is something that people actually need as healthcare.
So actually, most of my clients are like younger. They're in their 20s, mid 20s. So I'm actually seeing the opposite, where like when they're reaching out to their doctors, you know, trying to get that referral to get to a fertility clinic, it's like, no, you're still young. And, you know, like it's more like, let's save this for the people that are older who are like, you know, like running out of time, basically, is what their doctors are telling them. But it's, and I'm finding that more of an issue, that they're getting told that they're too young.
Okay,
And then the
interesting.
other thing is like the OHIP only covers the one round of IVF for couples or individuals who are under, I think it's 43. So, you know, anybody past that point, they're not able to access that.
So there's like a little perfect window in the mind of some providers.
That's
You
it.
have to be in this zone where you're eligible for treatment. That's really interesting that people can be told that they're either too young or too old for their family planning goals.
It's also clinic specific, because I know in Ontario, it's that 43 and under. And then in Nova Scotia, I've heard that they'll support people 49 and under. So it's then searching for the clinic that, you know, is going to be best for you with your age. And so, but like you said, some clients are being told, don't worry about it. You're young, you have so much time. And then when they're advanced maternal age, they're saying, are you a little bit too old to be thinking about this? You know, and then you get the people in between who have secondary infertility. They had no issue conceiving the first time, are struggling the second time, and then are being told, well, you're lucky you have one, or, you know, why are you bother trying, and why are you going through IVF when you already have one? And it's like, don't take away the fact that they would like to have a second, like many other people who don't struggle. And so it's difficult because people in fertility are constantly being told something that deters them from going forward. It makes it harder in this space to continue forward when they're getting negativity from people they know, people they don't know, from the medical system. And they're constantly having to advocate for themselves. If they don't know how to advocate for themselves, or they don't know how to get the support, they often don't go forward. So that's where we come in. Like, our jobs as doulas and support people and educators are helping people navigate this very complicated system.
Yeah, definitely. I think that stigma, all the stigma that we're talking about ends up being stigma around how we conceive of family and who we think of as parents, or the ideal parents, and who we think of as like struggling versus like easy, who we think of as fertile and infertile, and all those assumptions. So I think often when we think, when like a healthcare provider, implicit bias kicks in. And when they think about family, we think of monogamous, we think of wealthy, we think of cisgender, we think of, often I think a lot of care providers think white, settler, like those are things that implicit bias will make those rapid judgments, so that implicate the kind of care that people receive. I think that has a huge impact on how individuals interact with clinics. And I think the truth about stigma is it doesn't really matter how much you experienced firsthand, because the expectation of stigma from other sources, if you've experienced stigma in other areas of your life, if your people in your community have experienced stigma, if people of your age group have, you're going to have that expectation, and that's already going to cause stress, right? And that's sort of part of minority stressors, is that it's not necessarily your firsthand experience, it's also the expectation based on your identity and your previous experience.
So do you feel that access to fertility care is a right? Because I feel like in many people's, like, it's kind of implied in what you've all said at different points in this discussion, and with some of the pushback that people hear when they're getting fertility support, it seems like the underlying message is that having children, or having a certain amount of children, is a nice to have, not a must have. And therefore, why should this be something that we support if it's not happening easily for you? I feel like there's a subtle implication around that. And with that fertility care is seen as a luxury. What are your thoughts on that? How that kind of thinking if I'm right about that being some of the underlying mentality, how it impacts your clients and how you work with them to disrupt that.
I think that's where we come in, where it's like when the client goes and they try to get that referral and then the doctor tells them something and then they come back and they tell me like, oh, they told me that I'm still young. So then I tell them, okay, so then you can push for things, so you can push, ask them to test, to do some hormonal tests, or, get an ultrasound done just to see in the meantime if there is something going on. Because if they're not at that 12-month mark, a lot of doctors are saying like, it's not the right time. So I think if they can't get that referral, at least try to push for tests, because that's easier to get done than to get a referral to get into a fertility clinic. So I think there are those options. So oftentimes doctors do say like, maybe it's not necessary yet. So like I said, that is a setback for them. But then after a few months, if they try again, I think with my clients, most of the time eventually they do get the testing that they ask for.
I can go. I think that when we're talking about this country, it's like very different than thinking about other places. When we're thinking about healthcare that's being provided to people, that should be provided to all people who are here. I think to me that means that equity in healthcare means that when our bodies aren't meeting the expectations that we have of our bodies, or they're not doing the things that we want them to do, or we don't have the materials to make those things, that should be covered, because that is what healthcare means. It means providing care so that we can access the things that everybody else in the country accesses, right? So, just because somebody else's body can do something that your body can't doesn't mean that there shouldn't be coverage for that. Equity doesn't mean that everyone gets the same care. It means everybody gets the care that they need. So yeah, I definitely think that is something. In order to have accessible healthcare, everyone has to have access to those healthcare needs.
Thank you. Jessica, do you have any final thoughts on that?
Yeah, I'm just sitting here thinking, why isn't it considered, baseline care? It's shocking to me that, some people actually think, well, if it doesn't work, then, why waste resources? Especially with birth rates going down, you would think that this would be a priority. And I'm trying to think of an example, like maybe it's, some cosmetic surgeries are covered because there's something that's benign that's really bugging a person, and they're able to access services to get cosmetic surgery done because it's important to them. And so growing your family is also important to some people. And so they should also access covered care to have that health service is the same as someone else. So I do think it should be essential, and it's a bit dated and absurd to think that, that shouldn't be something that anyone who wants it should access.
Okay. So it sounds like cost is like one of the key dimensions of access and all of this. I'm noticing that we are kind of at time, and I know some of you have other commitments this afternoon. So thank you so much for being here today. What would you say to somebody reaching out to you who is concerned about the impact that things like their access to funds is going to have on their ability to meet their family planning goals?
So most provinces will do baseline fertility testing that's covered under the provincial health. So the first step would be to figure out what's going on with the body. Is it a medical, like reproductive diagnosis, that there's an issue there that needs to be corrected, and that would be covered under the provincial healthcare? Sometimes it's something that's as simple as medication that could be covered under the medical plan. So I think the first step would be to figure out, what's going on, and that doesn't necessarily cost anything. The first steps of getting that blood work or a semen analysis, you can do that through the province that's covered. It may mean though that you might have to travel maybe to a different area if the wait list is really long and you're not willing or able to wait 1-2 years for that appointment. Maybe it means traveling to a different city to get that appointment and to get that test. So the first step would be figuring out what's prohibiting you from being able to be successful in this journey.
Okay. I feel like we need to cycle back to the regionality piece. That was one of our topics last year, just the impact that location has on your access to healthcare. And it's come up again in this conversation as well, which will of course add to the costs if you have to travel or face that or waiting 2 years. Laine and Zakira, what are your sort of final thoughts on what you would say to somebody who's concerned about their chances based on these challenges?
Yeah, definitely. I think that the biggest thing is to reach out to supports, reach out to ask the questions that you have, and reach out to find out what questions to ask. I think we often don't know the questions to ask. We think depending on the province you're in and the city that you're in, there might be a lot of fertility clinics or there might be very few fertility clinics. So in both situations, like what kind of questions are you looking to ask? And I think that just like knowing that there are communities out there that have answers for you is a really important sort of first step. And I think also just to think that like to recognize that the clients, the struggles that the clients are experiencing are that sort of first tier. I think as doulas and healthcare providers, like our work goes beyond that and has to also be about implementing change at a more systemic level, advocating for our clients at the clinic level, and also advocating for policy changes that make things more accessible. I think like we have to include that in our own work to make it easier for our clients.
Okay, amazing. Thank you. I love that point about how the systemic advocacy is a part of our work with individual clients. It's a big part of what we've been talking about at Doula Canada right now. Zakira, do you have any closing thoughts?
Yeah, no, they've covered basically everything that we would say. I do have some patients when I was working at the hospital, they would say, they got help from their family members because there was no way that they were able, some people had to do 3-4 rounds of IVF, right? There was no way they were able to afford it. So, they had to ask parents or in-laws to help them. So I think that's what it is start off with seeing what you need, how much of it is going to be covered by your healthcare, and then how much of it is covered by your insurance, private insurance, and then reaching out to family if there's anybody that's available to help.
So the importance of being willing to ask for help and kind of get past any of the internal barriers around your own feelings of stigma and whatever your challenges might be, about saying to your community, like, hey, I need this GoFundMe. Hey, this is the support that I need to do something that's really huge for me. And, until we live in a world where this is just kind of freely given the way that it would be with other kinds of healthcare, I think that's a really valuable insight as to what self-advocacy looks like here. Okay, thank you so much for your time today. This has been a really valuable discussion, very eye-opening for me. And I hope that it's been informative for everyone who's tuned in today. Thank you very much. And I hope that we can keep having these discussions. We'll be back in April with a discussion on teen pregnancy and equity access issues. Okay, have a great afternoon, everyone.